Hello, Dr. Nora Volkow. It's an honor to have you here with us today. And as a member of Rio Grande do Sul Association, I'd like to thank you for this interview. We've selected 14 questions from several psychiatrists from our region. And the first question is, can you tell us how did you decide to move from Mexico to New York to become a neuroscientist?
Because I read an article on the Scientific American where they were describing this new imaging technology, positron emission tomography, that actually allowed you to look inside the human brain. So I had, at that point, I said I wanted to go and do research with that instrument. And I went to the United States and I volunteered to work as a researcher. And I got so engaged that I ended up staying, and I completely changed my plans from going to MIT and finish a residency training in psychiatry at New York University. And I've been working with this technology since then.
Considering your body of research in neurobiology of addiction and also the psychosocial factors related to such disorder, do you think that a therapeutic model based on prevention strategies, including biomarkers as predictors to drug abuse, would be feasible?
I think that we will start to develop biomarkers that can give you a sense of risk of someone's vulnerability for taking drugs. And in fact, we already have some characteristics that can tell us who is at greater risk. For example, in any child or adolescent with mental illness is much more vulnerable for taking drugs and then to go into the transition of addiction. We also know that kids that come from families where there's a lot of drug use, they are also likely to be more vulnerable for taking drugs. Similarly, it is recognized that kids that have poor self-control, which can be seen very early on, are at greater risk of taking drugs. So we already have certain characteristics that should alert us as psychiatrists of those individuals who may be at greater risk. Of course, as new technologies are evolving, like brain imaging, as well as genetic markers, in the future we could conceive of having these type of tools help a psychiatrist ultimately determine a level of risk. Nonetheless, regardless, we are always going to be, for psychiatric diseases, faced with the notion that they evolve as an interaction between biological factors that make you vulnerable and environmental stimuli that can actually act to prevent or facilitate that transition. And in the case of drug use, we know that factors, environment, access of the drug, stress, all of those factors are going to interact to increase the likelihood of someone taking drugs, whether they have or they don't have the genetic vulnerability. So it's ultimately that interaction.
And how much time do you think would have these biomarkers?
Well, I don't like to play magician in terms of how much time. What I can say is right now, with the new developments on resting functional connectivity that allow you to assess relatively rapidly in 5-10 minutes of scanning with MR, whether the connections between areas of the brain are disrupted or not, has opened up the door for the feasibility of having biomarkers of brain function. And for example, there's already data that shows that these biomarkers can be used to determine who is suffering from severe pain and who does not. And as these studies get done and established, we will be able in the future to have, for example, similar type of map that can help us differentiate people that are addicted versus non-addicted, as well as differentiating those individuals that may have disruption on self-control and therefore more vulnerable. So this is something that I could see evolving really in the next 5 years.
In Brazil, we are facing a serious public health problem regarding crack cocaine use. What do you think about the molecular mechanisms of crack in comparison with snorted cocaine? Are they the same?
Well, you have cocaine, and the main difference is the route of administration. When you're snorting cocaine, you are actually taking it by a route administration that takes a relatively long time to reach the brain. When you are smoking, when you're taking crack, you smoke it, and that immediately delivers the cocaine from the lungs directly into the brain. And we know that the speed at which the drug gets into the brain is actually one of the important variables that determines how rewarding and addictive they are. And that's why cigarettes, which you smoke, are so addictive, because you're immediately delivering the nicotine into the brain. The same is distinction we have with crack cocaine. You're smoking it versus snorting, which will lead to slower concentrations, slower and lower concentrations. So the drug is the same. What you're varying is the speed at which it gets into the brain and the ultimate amount of the drug that will get there. And with crack, you'll get it faster and higher concentrations.
But the treatment probably should be different.
Well, the treatment itself is going to be dependent on the severity of addiction. And because the crack route of administration, crack cocaine, is more efficient in delivering high concentrations, just by probability, it is going to be likely that the people that are taking crack are going to be more severely addicted than those that take snorting. And thus, the treatment of someone that's more severe require a more intensive intervention. But it is cocaine, and you could find individuals that may be snorting huge quantities and are severely addictive, in which case the interventions is also going to have to be very intensive.
How close are we to be able to extinguish memory triggers associated with addiction in humans?
That's an interesting question, where a lot of researchers are interested in addressing this, for example, for post-traumatic stress disorder. And there are interventions that actually have been shown that you can allow to erase a memory. And this, in a way, interestingly, is done easier for a situation like post-traumatic stress disorder than with addiction. And why is that so? What happens with post-traumatic stress disorder, the bad experience is linked with a very specific experience that the individual had. Whereas when someone takes cocaine, that experience of taking cocaine is associated with a variety of stimuli. And thus, it is easier to erase one memory, as it is the case on drug addiction, where you would have to erase the association of the pleasurable responses on the place that you took the drug, with the people that you took the drug, on the emotional experience that you had when you were taking it, whether you were stressed or not. So there are so many associations that are made with cocaine that have made this a very challenging strategy for the treatment of cocaine, for the memories of cocaine. Nonetheless, for example, there are researchers that are trying to see if through the use of biofeedback with imaging, or are there certain medications that one, for example, could give that could help a person in a therapeutic intervention be able to erase that memory. So even though it's more challenging, there are many very good brains working on trying to address this question. There are medications that are being developed to actually, in a psychotherapeutic session, allow you to extinguish the memory faster. Now, those medications are still in the preclinical world, and the extent to which they can be translated into humans needs to be determined. But in animal models, there are clearly medications that allow you to extinguish faster, and extinguishing is the equivalent of forgetting in a person.
Why in the US is cannabis considered an illegal substance and as dangerous as heroin? Considering this, we know that in some states people can use it within medical purposes. Do you believe in the therapeutic potential of this substance?
First of all, I don't think that in the United States people consider marijuana as dangerous as heroin. In fact, heroin is particularly dangerous because of the problem that you have of dying from overdose. And all of the opioids actually, viewing that context, have some of the highest mortality rates associated with drug use. Cocaine also is associated with high mortality secondary to seizures and cardiovascular and cerebrovascular accidents. Whereas marijuana, the mortality associated with marijuana is secondary, and it's linked with accidents associated with driving under the effects of the drug. But otherwise, to my knowledge, there's really not, there's always exceptions, but there are no cases of overdosing from marijuana. The other one, the addictiveness of heroin is much greater than that of marijuana. So I don't think anyone in the psychiatry world or in the clinical world would state that marijuana is as dangerous as heroin. Having said that, a question that has led a lot of people to ask, is marijuana harmful? And there is evidence that marijuana is harmful from different parameters, including the fact that it can produce addiction. Also, when one addresses the question, is marijuana harmful, one also has to address it, it depends to whom, right? So you're willing to tolerate more harm in an adult than in an adolescent or a child. And there is evidence in the literature that use of marijuana during adolescence can actually interfere with the cognitive and emotional development of that individual. And in that respect, one can say that marijuana use in childhood and adolescence is deleterious. One can also say that marijuana use during pregnancy is clear-cut deleterious. And then there's data out there in adults showing that it's not good for your memory, it's not good for your cognitive capacity, nor is it good for your motivation. But anyway, that is not as clear-cut as it is for adolescents. To the question, are there potential therapeutic applications for cannabinoids? Absolutely. And the issue is cannabinoids, which interact, among other things, through cannabinoid receptors on membranes, but there are also interactions that appear to be directly related to nuclear effects, nucleus of the cells, are very relevant because they are all over our body, not just in our brain, but they are in lymphocytes. They are also present in the liver, and they modulate multiple physiological functions. So it's therefore not surprising, for example, that pharmaceutical industry are working on cannabinoids for a wide variety of indications, including pain. And we are funding researchers to develop cannabinoids that could be used as potent analgesics without the adverse effects that opioid medications have. There's also evidence that these cannabinoids, some of the cannabinoids, particularly those that interact with the cannabinoid type 2 receptor, have strong anti-inflammatory effects. And this is why some people use marijuana for the treatment of multiple sclerosis, for control of symptoms. There's even evidence in the literature of cancer research that certain cannabinoids, again, those that interact more through the cannabinoid type 2 receptor, can have beneficial effects for certain types of cancers. Now, when one has this information, does that equate by the fact that said marijuana is therapeutically useful? I think that is a long gap. The fact that cannabinoids can have potential beneficial effects does not make marijuana a medication. First of all, the marijuana that one gets is extremely variable, not just in terms of potency, but very importantly, in the content of cannabinoids. So someone smokes marijuana, there's multiple cannabinoids in that marijuana, and the therapeutic effects are actually, for example, more potent for cannabidiol. So what we're speaking about, anti-inflammatory effects, what we're speaking about, potential anti-carcinogenic effects, are mediated by cannabidiol. Now, the content of cannabidiol varies enormously across marijuanas because cannabidiol antagonizes the effects of 9-delta-tetrahydrocannabinoid, which is why people smoke marijuana. So therefore, the use of marijuana is far from ideal as a medication, but on the other hand, it really has allowed researchers to see that these compounds, the development of tailored compounds to maximize positive effects while minimizing negative effects, is a tremendous source for very interesting type of compounds for a wide variety of medical diseases.
Considering the decrease in dopaminergic activity observed in aging and the patterns of consumption among older populations, do you have some thoughts about aging and addiction?
Yes, indeed. It's clear. One of the things that's very interesting is, of course, for a wide variety of drugs, the rate of drug use goes down with aging. And for example, it's very difficult to find people, cocaine abusers, cocaine addicted individuals that are more than 60 years of age. Now, you can make the statement that it's because they die. Well, that's a possibility. And indeed, for example, for heroin addiction, we're seeing that the rate of death is very, very high. Now, we do observe alcoholics that are very older, but they also tend to decrease the consumption of alcohol. And one of the things that happens is as people age is that the untoward effects of the drug start to antagonize and interfere with the pleasurable component. So someone is 50 years of age, takes cocaine, and starts to have chest pain that's very intense, that is going to be an adverse reaction, and they are not going to want to take it in the future. So there is that element that's playing around. The brain dopamine system is much less sensitive to rewarding effects of drugs as we age, and that's a normal process that makes us also less sensitive to other natural reinforcers. Though curiously, I don't know that that is to be the case for food. I mean, interestingly, I don't think that the capacity of humans to process pleasure from food decreases with age. But in terms of a wide variety of other stimuli, it does seem to be the case. Now, can we use this as a lot of people were sort of very intrigued about it and say, well, if there is a decrease in drug taking with aging, could we use that to try to do it as an intervention for preventing or treating substance use disorders? And the answer is, of course, not, because what you don't want to do is actually emulate a normal process that happens to age to address the problem of drug addiction. And what is paradoxical, seemingly paradoxical, is that if you take a person that's addicted to drugs and you do a brain imaging study to assess the reactivity of the dopamine system, those individuals look as if they were older than their age. So it seems like drug taking accelerates that process of aging. So we know that is not going to work. And if anything, right now, it appears that having a decreased reactivity of the dopamine system when you are young and not as the normal process of aging makes you more vulnerable for taking drugs. And interestingly, what the field is also finding is the same thing. If you have a decreased reactivity to food as a young person, that may, in fact, make you more vulnerable to overconsume, perhaps as a mechanism to compensate.
I would like to know your opinion about bariatric surgeries indicated to morbid obesity, considering that many of these patients will present psychiatric complications after surgery. Do you think that such procedure can really treat obesity? Can it impact neurofunctioning?
Well, it's a question for which we don't have many answers. We've been studying it in humans and in animal models. And what I can say, first of all, is bariatric surgery can be life-saving for individuals with morbid obesity in whom other interventions have not worked. And the reality is that people that are morbidly obese are at high risk of very serious medical complications that in average are likely to reduce their lifespan by 10 years. So morbid obesity, if not treated properly, will lead to complications that will ultimately lead to the mortality of the individual. And the data is there. Bariatric surgery overall provides a therapeutic benefit that counteracts some of the risks that are associated with it, including sometimes there's mortality from the surgery. So it's not, it's a drastic procedure that is required because the consequences are very drastic. Now, having said that also, and to your question, are there adverse consequences? One of the consequences that I've been particularly interested, that has intrigued me enormously, is the fact that individuals that undergo bariatric surgery are at greater risk of developing compulsive disorders like alcohol drinking. And in the United States, for example, one of the counterindications for having bariatric surgery is a past history of alcoholism. Because if you undergo the surgery, you will actually very likely relapse. And so we've been doing this in animal models to try to see whether bariatric surgery, after bariatric surgery on these animal models, changes sensitivity to drug rewards. And we published that, and there's another group that has also published on this, that it does increase the sensitivity to the rewarding effects of alcohol. And now we're doing the studies to see if, in addition to alcohol, it may be affecting the sensitivity to the rewarding effects of other drugs. But the data is out there that it does increase the sensitivity to the effects of alcohol.
As you know, crack is one of the major problems in Brazil. There is a lot of discussion about compulsory treatment, especially compulsory detoxification. There are pros and cons, but the core issue is related to whether the user has or has not the judgment and decision-making preserved to seek treatment. Considering the human rights policy, what is your opinion about this issue?
It's a complex one because, of course, you want, ideally in a situation, you want the individual to say, I want to be treated, and therefore provide with the treatment, so the individual has the choice of seeking treatment. Unfortunately, one of the things that happens in drug addiction that makes this issue so difficult is that it interferes with our capacity of self-awareness. And there is evidence from neuroimaging studies, for example, that people that are addicted to drugs have damage, among other areas of the brain, in the insula and in the anterior cingulate gyrus. And those two brain regions are crucial for the ability of interoception and awareness of pathology. And so the denial, which we call denial of disease, that many people that are addicted, alcoholics, cocaine abusers, says, no, I don't have any problem, may in fact reflect the fact that the areas of the brain that you require in order to be aware that there is a problem are harmed. So the situation is in that case, how do you then at the same time protect the right of an individual of privacy and self-determination? So if the areas of the brain do not allow you to see pathology. And I think that there is a way of trying to determine on the basis of what are the consequences to the individual, and psychiatry has been dealing with it. So if the consequences of the disease put the individual or others at risk, you can intervene and treat against the person's will. So in this respect, it's not any different from other mental illnesses, where we can, for example, if someone is at risk of committing suicide or harming someone else, as a psychiatrist, you can admit them for treatment. And then, of course, there is due legal process and medical expertise required to determine can you continue it, but at least you can initiate the treatment process, and then you can provide the information to actually document whether that person is in risk of harming himself or herself or others. So I would apply it like I would do with any other mental illness.
How could we assess the degree of risk to addiction before someone consumes for the first time alcohol and drugs? Do you believe that it would be possible to predict who will become addicted?
I don't think we'll ever be able to predict 100% who's going to become addicted, because first of all, addiction is not a totally categorical black or white. And I mean, the addictiveness is a dimensionality. So, and again, I think at la limite, if someone is placed in a very adverse environment where there's nothing to do but only take drugs, the probability of them starting to take them and becoming addicted to a certain extent in that context is real. So we have to consider all of these issues vis-a-vis a context and severity. Now, within all of these things that I've stated, at the same time, as I stated before, if you have a mental illness, schizophrenia, depression, attention deficit hyperactivity disorder, anxiety disorder, all of them are going to be increasing the likelihood that you will use drugs, which in turn, by probability, will increase the likelihood of you becoming addicted. Other variable, how early do you start? And now we know that the younger you start taking the drugs, again, the greater the probability that you become addicted. So you already have two factors that are very relevant. Stress exposures. In situations where an individual is on very adverse environments that lead to high levels of social stress, we already also know that that's going to increase the probability of them becoming addicted. So you have three factors. The age of initiation, presence or not of mental illness, and exposure or not to social stressors that allow you to determine relative risks. In the future, as we get information, for example, on genetics, actually, right now, family history, a fourth factor. So if you come from a family history of your grandfather, your uncle are alcoholic, you are likely going to have some of those genes. So we already have sufficient factors to be able to balance certain levels of risks. Can genes tell you 100%? I think that no. If it were, we already would have found those genes that make you, yes, you're going to have 100% chance that you're going to become addicted. It's not like Huntington chorea. Huntington chorea, if you have the gene, you're going to develop the disease. The question is how long it's going to take, how old are you going to get until you develop it. With addiction, you have the genes. What they are going to do to you is make you more or less vulnerable to factors in the environment that then are going to determine whether you transition into addiction or not.
How much do you believe that cognitive remediation, for example, cognitive training for attention or memory, could help in substance abuse treatment, and why?
Well, I think that they definitively could help. I think part of the problem that emerges among the multiple effects of drugs on the brain is that it does interfere with your capacity to pay and sustain attention, as well as operations that require cognitive memory, in which you have to sustain in your working memory capacity information that allows you to make proper decisions and judgments. This is most disrupted in people during the first few days after abstinence, but can take up to 1 year or more to recover. And we don't actually know if it completely recovers in all patients. And it's likely that in some patients with very chronic histories, with multiple drug use, with high doses, this may not completely recover. Now, these cognitive impairments in attention, in working memory, in judgment, are going to interfere, among other things, in the capacity of the individual to recover and achieve participation in a productive way into society. But it's also going to interfere with the ability to engage into a psychotherapeutic intervention. So if you have a patient and you are doing a behavioral intervention and the patient cannot pay attention, you're just, in a way, losing your time because you cannot have him or her focus. So even from that very simple, practical perspective, improving the capacity of your patient to sustain attention and to follow what you are telling them is likely to lead to better outcomes of your psychotherapeutic intervention.
Considering drug abuse as an impulsive-compulsive problem impairing the risk evaluation capacity, how could we improve our therapeutic approaches in order to generalize it to other impulsive behaviors, such as gambling or eating disorders?
Well, I guess that the notion of how do you address impulsivity with respect to a psychotherapeutic intervention, in a way, would be dependent on the patient, the impulsiveness, understanding under what and conditions the person develops an impulsive behavior and under what mental state. So if it is they become impulsive when they are stressed, or are they constantly impulsive, or are they impulsive when they encounter the reward, be it a drug or food. And depending on those characteristics, you are going to do an intervention, and the intervention is going to start by making that individual aware of the circumstances in which the impulsive behavior emerges, such that they can try to avoid being in those circumstances, and they can prepare themselves beforehand to have an alternative response. So for example, if you have a person that's very impulsive that eats the moment that they see the food, you as a therapist are going to say, I want you to be prepared. You're going to be going home, you're going to have the food in the refrigerator. I want you to do an exercise where you are actually going to go and open the refrigerator, but you are going to actually inhibit that tendency to take the food. So you train them, you have them do these exercises, and then you start to generalize them. So again, it's like with any other therapeutic intervention that you're going to be doing to teach your patient to be able to manage a behavior, to inhibit a behavior that normally they would show when they are exposed to a certain context or emotional states, because that's the other aspect that drives a lot of the impulsive behavior.
What is the biological explanation for why someone, after so many years without using drugs, persists with craving and risk of relapse?
Well, the belief is that the changes that are produced by drug at the molecular level as well as the circuit level are very long-lasting and persist actually years after the person has taken the drug. And this in turn is believed to be the reason why even after years of remission, a person can relapse when placed in circumstances where they get exposed to the drug or when they are very stressed. And in fact, studies in laboratory animals can emulate this. So you can get an animal addicted to a drug, then you discontinue it for a very long period of time of that rat's life. You expose them back into the laboratory and they can relapse. So even though they had a long period of time where they were not exposed to the drug, when they are brought back into the circumstances where they used to take the drug, they immediately relapse. And that's actually a long-lasting memory that triggers a cascade of behaviors.
But I think there are some people that maybe lose their memory rapidly or not.
Oh yeah, there's tremendous differences in the ability of people to actually recover from drug taking, like there is in animals. You can take animals in who you extinguish this very rapidly, and there are animals which take very long. And also after you've made them abstinent, say for 3 or 6 months, there are some animals that escalate much more than others. There's biological diversity that relates in part also to how strongly you created these conditioned responses and how persistent they are.
The development of anti-drugs vaccines appeared to be an innovation in drug dependence treatment. However, clinical trials have been shown mixed results regarding efficacy. What is your opinion about that?
The problem with the vaccine trials and the vaccines that we currently have is that they are not sufficiently potent, so they are not sufficiently antigenic. And as a result, at least for the 2 clinical trials that have been done, one nicotine vaccine, the other cocaine vaccine, only a very small percentage of individuals develop sufficient antibody titers to reach the therapeutic level. And thus, overall, if you look at the whole clinical trial, the effects don't become significant. It's interesting because in both nicotine and cocaine, however, individuals in whom there are high levels of antibodies, they do show decreases either in nicotine or in cocaine consumption. And certainly in animal models, where they've been able to develop vaccines that are much more antigenic and testing them there, they actually are able to decrease cocaine consumption and nicotine consumption and heroin consumption. But in animals, I always say it's very easy to treat mice and rats. It's much harder to treat humans. So we still have the challenge of bringing up vaccines that will be sufficiently potent to generate antibodies that are necessary for therapeutic efficacy. And until we have those vaccines, we won't really know whether the strategy will work for humans or not. If we ever get a vaccine that can reach high levels of antibodies that are long-lasting and has no untoward effects, my answer is why not? I mean, what is the positive aspect of taking cocaine or heroin? I mean, you may die from overdose, you may have a whole adverse series of effects. So in my view, if one were to develop a vaccine that has no untoward effects, that really protects, absolutely, why not?
Finally, can you give some advice to the young generation of Brazilian neuroscientists and clinical psychiatrists?
I think that this is probably one of the most exciting times for psychiatry and neuroscience, because on the one hand, we have all of the developments that are coming out of genetic research. And on the other one, we have access to brain imaging technologies that really also are breaking through into what we will have in the next few years, biomarkers. So therefore, we will be able not just to assess a patient on the basis of their symptoms and characterize them on the basis of the clinical presentation, but also we will be able to characterize them vis-a-vis the functions and deficits on the various circuits. And based on that, we may be able to do tailored intervention to strengthen those circuits that are not functioning properly, and that way try to buffer the function of the brain in a way that will allow that patient to recover faster and better.
So those are all the questions that we have for right now. We know how busy you are, and we'd like to thank you very much for taking the time to answer our questions.
Thanks to you.